Common disorders of the respiratory system and oxygen therapy. Chronic obstructive pulmonary disease is a group of lung diseases that block airflow and make it difficult to breathe. Emphysema and chronic bronchitis are the most common conditions that make up COPD. With emphysema, the alveoli become overstretched. Carbon dioxide remains trapped in the alveoli. Shortness of breath, coughing, and difficulty breathing are common. With chronic bronchitis, inflammation of the bronchial lining occurs. Chronic cough with thick, whitish sputum is common. This restricts airflow and scars the lungs. Damage to the lungs from COPD cannot be reversed. The resident will become progressively worse over time. There is no cure. Causes include cigarette smoking, environmental air pollution. Symptoms include coughing or wheezing, dyspnea, shortness of breath, cyanosis, complaints of chest tightness, confusion, weakness, loss of appetite and weight, fear, and anxiety. Some guidelines for caring for the resident with COPD. You can use pillows to assist the resident to sit up and lean slightly forward to facilitate breathing. Plan periods of rest when completing activities of daily living. Practice good hand hygiene to prevent infection. Encourage a healthy diet and provide plenty of fluids. And be supportive and calm if the resident is anxious. Some things to report to the RN regarding COPD are signs and symptoms of cold or the flu, which would be fever, chills, complaints of feeling achy, confusion, any change in breathing patterns, shortness of breath on exertion, complaints of chest pain or tightness, and insomnia due to anxiety or fear. Acute bronchitis is inflammation of the lining of the bronchi caused by an infection. Symptoms include production of yellow or green sputum or mucus, difficulty breathing, and wheezing. Acute bronchitis lasts only a short time. Asthma is a condition in which the patient's airways become inflamed, narrow and swell, and produce extra mucus. It is a chronic condition. Some causes include allergens, infection, cold air, environmental irritants, obesity, and family history. Signs and symptoms of asthma include wheezing, coughing, complaints of chest tightness, and difficulty breathing. Some things to report to the RN are changes in respirations and pulse, wheezing, shortness of breath, cyanosis, complaints of chest pain or chest tightness. Pneumonia is acute inflammation of the lungs. It can be caused by an infection or a chemical irritant. Signs and symptoms include fever, chest pain during inhalation, coughing, difficulty breathing, shortness of breath, chills, tachycardia, or thick-colored sputum. Hospital-acquired pneumonia is pneumonia that occurs 48 hours or more after hospital admission. Ventilator-associated pneumonia, or VAP, represents a subset of hospital-acquired pneumonia that occurs within ventilated patients. Community-acquired pneumonia is a type of pneumonia found in people who have not been in the hospital or another healthcare facility. Some things to report to the RN: any changes in vital signs, complaints of difficulty breathing, complaints of chest pain or discomfort, and any unusual sputum production. Some altered respiratory functions. Respiratory depression is slow, weak respirations, so less than 12 breaths per minute. Respiratory arrest is when breathing stops. Hypoxemia is reduced amounts of oxygen in the blood. Hypoxia is when the cells do not have enough oxygen. Atelectasis is the collapse of a portion of a lung. Atelectasis occurs when mucus collects in the airway. Surgery, bed rest, lung disease, and paralysis are risk factors. Some medications can cause respiratory depression. Drug overdoses can cause respiratory arrest. Some abnormal breathing patterns. Tachypnea is rapid breathing, so it's a respiratory rate of greater than 20 per minute. Bradypnea is slow breathing, or a respiratory rate of less than 12 per minute. Apnea is the lack or absence of breathing. Hypoventilation is when breathing is slow, shallow, and sometimes irregular. Hyperventilation is when breathing is rapid and deeper than normal. Here are some additional abnormal breathing patterns. Dyspnea is difficult, labored, or painful breathing. Cheyenne-Stokes respirations are respirations that gradually increase in rate and depth and then become shallow and slow. Breathing may stop for 10 to 20 seconds. Some causes of Cheyenne-Stokes respirations are drug overdose, heart failure, and renal failure. Orthopnea is breathing deeply and comfortably only when sitting. Some causes of orthopnea are emphysema, asthma, pneumonia, and heart issues. Biot's respirations are rapid and deep respirations followed by 10 to 30 seconds of apnea. And causes of Biot's respirations are nervous system disorders. Kussmaul respirations are very deep and rapid respirations. They signal a diabetic coma. Oxygen therapy is the administration of oxygen to improve oxygen levels in the blood. Normal blood oxygen levels, or SpO2, are 95 to 100%. Residents with certain diseases will have different normal oxygen levels. For instance, patients with COPD may never see an SpO2 greater than 92%, and you would not put them on oxygen because they are used to being in oxygen deprivation. Oxygen is a medication. It requires a physician's order. It's ordered in liters per minute. The nurse aide may only observe and report administration of oxygen. They are not allowed to put it on the patient. Methods of oxygen delivery are compressed air or an air condenser. Compressed air is the green oxygen tank, or it's in a wall unit. An air condenser connects to an electrical outlet and pulls out air in the room. And there's some pictures on the next slide. So you can see the wall unit and then the green oxygen tank. So that's compressed air oxygen delivery. And here you can see air condensers, and this is what you would see in a patient's home. Some oxygen appliances are the nasal cannula, which are two nasal prongs and tubing that goes around the ears and cinches under the chin. The tubing is attached to the oxygen source. You can also use a mask. It's called an oxy mask in the hospital. The mask fits over the nose and mouth and attaches to tubing, which is attached to the oxygen. You can also use a non-rebreather mask, which allows for delivery of higher concentrations of oxygen. And there's a picture of all of these on the next slide. With nasal cannula, if it's anything greater than 3 liters, you need to make sure it's humidified so that the nasal passages don't dry out. If it's greater than 6 liters, you put on a mask, and a non-rebreather goes up to 15 liters. Then here's a picture. You see the gentleman with the nasal cannula. The middle picture shows an oxy mask, and then the last picture shows a non-rebreather. Some guidelines for oxygen delivery. You want to ensure that the oxygen tubing is not on the floor. No smoking is allowed in the same room as oxygen administration. A no smoking sign should be inside and outside the resident's room. Any spark can cause a fire in the presence of oxygen, including static electricity from wool and dry air in the winter. It's important to perform frequent skin care to the areas in contact with the oxygen appliances. Patients can get pressure injuries from oxygen appliances. The CNA should report the following to the RN: any sores or crusty areas under the resident's nose or around the ears, dry red areas on the skin in contact with the oxygen tubing, shortness of breath, changes in respirations or pulse, changes in the character or color of the sputum, cyanosis, or complaints of chest pain or tightness. Artificial airways keep the airway patent, or open and unblocked. Artificial airways are needed when disease, injury, secretions, or aspiration obstructs the airway. For mechanical ventilation, by some persons who are unconscious or semi-conscious, or during surgery and recovering from anesthesia. Mechanical ventilation is using a machine to move air into and out of the lungs. Intubation is the process of inserting an artificial airway. An oropharyngeal airway is inserted through the mouth and into the pharynx. This is done by a nurse or a respiratory therapist. An endotracheal tube is inserted through the mouth or nose into the trachea. The cuff of the tube is inflated to seal the airway. The seal prevents air and fluid leaks around the cuff. This is done by a physician. A tracheostomy tube is inserted through a surgically created opening into the trachea. Air, blood, or fluid can collect in the pleural space, which is the sac or cavity. This occurs when the chest is entered because of injury or surgery. The doctor inserts a chest tube to remove air, blood, or fluid. This is a sterile procedure that is done during surgery, in the emergency department, or at the bedside. Pneumothorax is air in the pleural space. Hemothorax is blood in the pleural space. A pleural effusion is the escape and collection of fluid in the pleural space.